Hello and welcome to the Neurocritical Care Society podcast. This is our Hot Topics series. I'm your host, Dr. Nick Morris from the University of Maryland. And today I am really excited to talk to one of the lead authors from the Guidelines for Seizure Prophylaxis in Adults Hospitalized with Moderate to Severe TBI, Dr. Jen Frontera. Dr. Frontera is a full professor at NYU Langone School of Medicine, and we are really excited to have her on the podcast. Jen, thanks for joining us.
Thanks. Awesome to be here. Appreciate it.
All right. Well, let's get right down to this. So, NCS commissioned, I guess, this guideline to look at seizure prophylaxis in moderate to severe TBI. This is something in neurocritical care that we think about every day, right? But why should we think about this? Why is it an important question?
Yeah, so I think our interest in looking at seizure prophylaxis sort of grew out of a recognition that there's a huge heterogeneity in practice in terms of what people do from one institution to the next at level 1 trauma centers versus non-level ones. And there's no guidelines that currently exist that have systematically looked at this. And I think there's been a concern over the last, let's say, decade about cognitive side effects related to anti-seizure medications. And so, we thought it would be important to systematically go through and look at what the data shows. And we actually were tasked initially with doing this for general neurocritical care. And so we had selected not just TBI, but subarachnoid hemorrhage, intracerebral hemorrhage, and supratentorial neurosurgery, where we frequently will use anti-seizure medication prophylaxis. Initially, we were going to just write one gigantic paper, and then we realized, no way, it's just, there are too many tables even for just one. So we divided it up into different, by different disease processes. And but we kept the same PICOs for each of the different ICH, SH, supratentorial, and TBI. So you'll see those coming along as we go.
That's exciting to see. I think you mentioned this, but I'd just like to bring it out a little bit more. When I sometimes talk to my colleagues, maybe in neurosurgery, who do a lot of neurotrauma, they kind of gloss over this question a little bit. Like, what's the big deal? Seizure medicines are really well tolerated. All my patients are on Keppra, sometimes I hear, right? And that's just fine. So, this idea that maybe they're not so well tolerated, where does that data come from, and what are your concerns?
So, initially the older data really, coming from the 1990s was looking at Dilantin and cognitive side effects from Dilantin. Of course, other older generation meds like valproic acid have side effects. So Dilantin, right? You have fever, drug interactions, elevated LFTs, Depakote, you have the, hyperammonemia, platelet effects, drug interactions. Even with Keppra, you get agitation, delirium. So, and all anti-seizure medications are sedating to some degree. So that can confound your exam. Plus you have the expense of the meds themselves, tracking therapeutic levels or target drug levels. And then a lot of times you'll see these patients that get discharged on an anti-seizure medication, people forget to stop it. Then they're on it for a very long duration of time and no one knows why. So yeah, it's a concern. So I think there are certainly downsides to using medications.
Great. Can you talk to us through a little bit, how does one go about starting a guideline like this? How did you create the panel? What disciplines and specialties were represented? What were you trying to achieve in doing that?
Yeah, so NCS moved more towards grade-based guidelines over the last several years. And in fact, more rigorous standards for using grade methodology. So we had to get trained in grade. We went to a course. Where now NCS is actually using grade methodologists to help with this because it is somewhat complex and rigorous. And so, NCS put the panel together. I'm not going to lie, I sort of insinuated myself into this because I was already sort of interested in how we use and dose levetiracetam for seizure prophylaxis. And so my co-chair is a pharmacist, Sean Rowe, and who was excellent. And we basically put together a group of people that was pretty inclusive, including not just pharmacists and neurointensivists like we are, but also nurses, epileptologists, who were suggested from the American Epilepsy Society. And, it's a diverse group of people from across the country. I will say most of us are from academic centers, so there is a little bit of bias in that regard. But otherwise, it's pretty extensive. And we also had a neurosurgeon on this group, recognizing that these are sometimes the primary treatment teams for TBI patients. And the neurosurgeon that we had was previously working on the Brain Trauma Foundation guidelines. So she was, well-versed in the material that we were discussing.
Great.
And I think a good representative of the Brain Trauma Foundation, even though she wasn't officially in that capacity.
Got it. Well, let's get to the sort of the meat of the paper now. What were the primary outcomes that you were interested in? I think you defined them as the critical ones of kind of indicating these have the most importance for the group. Yeah,
so I think, everybody thinks functional outcomes are the end all and be all, and I don't disagree with that. But expecting the use or not use of an anti-seizure medication to have a major impact on functional outcomes after TBI is, I think, you would require gigantic studies to power such effect, and they don't exist. The most important thing we really were concerned with is whether or not they actually are preventing seizures, be it seizures in the hospital or seizures in a delayed effect or post-traumatic epilepsy. And then we're also interested in adverse events. So the major, risk-benefit ratio during hospitalization. We did look at functional outcomes, which tend to be heterogeneously measured, even though modified Rankin and Glasgow outcome score are very popular. The way they're looked at is often heterogeneous throughout the literature. We did look a little bit at cognition, but there's not a ton of literature on that, although we do bring it up and mention what there is. And then, I think a cost effectiveness analysis would have been great. And we really did want to do it, but it's just the scope started to be really large. So we had to limit ourselves. And unfortunately, there's not tons of data with more recent ASMs like levetiracetam or lacosamide that some folks like to use.
Great. And maybe can you highlight for the listeners, which ASMs did you include in this review? Because it wasn't all of them.
Yeah, so we primarily were looking at phenytoin/fosphenytoin or Dilantin and levetiracetam or Keppra. And that's just because there's just much more literature pertaining to these. Valproic acid is a great anti-seizure medication, and there is some literature looking at this. But, nowadays, I think I don't really expect people to use valproic acid prophylactically for all the previous reasons mentioned, including drug interactions, hyperammonemia, platelet effects, et cetera. And I'm old enough to remember when we only had Dilantin and Depakote IV, and we would use them together and they would interact, and nothing was ever therapeutic at any given time because of the albumin binding. And the hyperammonemia was more frequent than you would think. And, it was problematic, let's say. And so I think I have some older generation PTSD regarding those meds, and I don't ever want to use them. But for prophylactic reasons, it's just not necessary. And we think that most people are going to use levetiracetam. And I would have loved to look at lacosamide or some other, new generation stuff, but there just wasn't that much literature comparing them.
Can you review the major inclusion and exclusion criteria for the guideline?
Yeah. So, and I'll just point out that, I think when we looked at seizure outcomes, we looked at early seizure versus late seizure. Mm-hmm. This was contentious, that 14-day stratification.
Yeah, I was going to ask you about that.
Oh, okay. And a lot of reviewers were like, it's 7 days. And I'm like, I don't disagree, except that every paper writes a different parameter. And if we only want to include one paper in a meta-analysis, there's not much to talk about. So, we want it to be as inclusive as possible. And frankly, there's no biological reason why someone would say 7 days or 14 days. Most of these patients are hospitalized probably for a median of like 10 to 14 days anyway. And during the hospitalization is that kind of acute time that you're interested in. So, that's basically where that stratification came from.
That makes total sense to me, to be as inclusive as possible and recognize that this 7-day time point is completely arbitrary.
Right. I mean, and also let's, the new definitions of both clinical, like the International League Against Epilepsy, clinical definitions, the American Clinical Neurophysiology, critical care EEG terminology, those things came out 2017, 2021, respectively. So that does not exist in the older literature. The methodology is much less robust than what you would apply today. So, we're dealing with what we have. And I think we have to sort of be inclusive to take those things into account. So I think you were asking inclusion exclusion criteria. So this is another point that was a little bit of a discussion with reviewers was how do you define moderate to severe TBI? Now, again, like we could not, like there were very few papers using any one different society's criteria, okay? And using admission GCS or loss of consciousness time, that would have brought us down to really, one or two studies. And, there's a nice review by Veterans Affairs online, and it has a table with all these different society definitions of mild or moderate to severe TBI. And there's 11 different society definitions, all of which are variable. What we're interested in here is the critically ill TBIs. We're not interested in concussion, for example, which some people refer to as mild TBI. So, the practical definition that we applied was patients that had a radiographic evidence of a TBI and required hospitalization for that reason. So we're not necessarily talking about the person that has a long bone fracture and is hospitalized with maybe 1 dot of subarachnoid hemorrhage, where the primary reason for hospitalization is actually the leg, for example. We're really talking about people with moderate to severe TBI in this particular paper. And so that was contentious, but again, we had to be pragmatic to try to be inclusive and remember the spirit of what we're trying to address here. We excluded patients that had prior seizures, had a prior history of epilepsy, were on an anti-seizure medication before the TBI for whatever reason. And we looked at only adults. There is of course, a entirely separate pediatric literature that was really beyond the scope of what we could basically address here. We did exclude, non-English language literature, preclinical literature, and then gray literature that are like abstracts or presentations or non-peer reviewed stuff.
Got it. Well, we're going to get to your findings soon, but I wanted just for the listeners to go a little bit through kind of defining the terms used in the methodology. So it's almost like a different language now when you speak guidelines. So can you take us through that a little bit? What does it mean when the panel says we recommend versus we suggest? To the average listener, those might sound exactly the same, but they're not. And then lastly, there's the sort of in our practice. So can you take us through that?
Yeah. So, when I took this grade course, my mind was blown because I had done the antithrombotic reversal prophylaxis or reversal guidelines. And we used quote unquote grade criteria, but we didn't really use grade criteria. When you get into the weeds on risk of bias rating, how you assess certainty of evidence and everything else, it's very prescribed. And, so if you follow the algorithm that grade teaches you, you will arrive at a recommendation. And honestly, the way you kind of go through the software, it basically creates an arrow telling you this is what your recommendation should be based on what you told me in terms of, biases and so forth. And so when you look at the bias, when you look at the aggregate of the literature, right, which is how you're coming up with your recommendation, you can rate the literature higher if, there's a large effect size, there's a dose response gradient, if there's some residual confounding that actually favors the comparator, but the intervention is still significant, that suggests that there's, it's a really important intervention. On the other hand, you can rate down the literature, meaning that it's less meaningful if there's a high risk of bias, if there's like inconsistency, which is heterogeneity across the studies. So that's your I-squared value. If that's high, that means that the studies are really giving different results. If there's indirectness, like you had to use a study to sort of infer whether the intervention works. Imprecision, meaning there's a big confidence interval or small sample size, and then of course publication bias, where you're less likely to hear about negative effects or adverse events. So all those things you combine in aggregate for the body of literature, and then it sort of points towards a recommendation. So if you're recommending something, we recommend, that means it's pretty clear that there's substantial benefits, trivial downsides, right? And it's an important intervention. And that most guidelines or, would say, yes, you definitely have to do this. We suggest is when, it sort of goes towards, probably something most people would do, but a reasonable person might not necessarily follow this. And that's, their prerogative, because there is, pluses and minuses to the literature. Now, in our practice section, we put in, because of the, critiques of grade. Grade is very stringent, it has barriers. And, when you wind up looking through the evidence, most things don't come out that strongly. There's very few things that are strong. And so we wanted to add something pragmatic about how we might interpret the literature. And that's, in our practice section. Now, I will say that of late, I've been more inclined to think that we should be doing Bayesian type meta-analysis rather than frequentist meta-analyses. And I'll tell you why. So some of the limitations that kind of are irksome about grade and the rigidity of grade can be addressed with Bayesian meta-analyses, rather than like the frequentist meta-analyses that we did for this particular paper. And so I think the benefit is that you get a wide range of posterior probabilities for effect sizes, right? So depending on whether the physician or the patient believes a certain effect size is meaningful, you can look at the posterior probability that an intervention is going to be useful. So for example, if you said, look, I think a 20% reduction in risk of seizures with this levetiracetam intervention, I think that's a meaningful reduction. We can go back and look with meta-analysis that there's, maybe whatever percent rate, 75% chance that you will have a 20% reduction in seizures if you use it. Other people may say 20% reduction is like nothing. It's not worth the side effects. I need to see a 75% reduction in seizure risk for it to be meaningful, right? And the analysis may say, there's only a 10% chance that levetiracetam will reduce seizures by 75%. So just to give an example, it kind of allows for differences in physician preferences in terms of weighting significance of adverse events versus the beneficial intervention. So it kind of gets around some of these limitations that a standard single confidence interval provides in a frequentist meta-analysis. So it's also less susceptible to small studies with extreme results that might sort of bias your summary statistic in like your forest plot. And I guess I'll get into that a little bit later when we talk about, what I do as a practitioner in terms of prophylaxis.
Right. Yeah, well, that makes a lot of sense to me because as you mentioned, different physicians, different even within fields, we may differ on the way we view our kind of motivation to prevent all seizures, right? And a certain percentage difference in seizure frequency may not be worth the trade-off in cognitive impairment or other things that come along with it to some of us. So I like that idea that maybe using Bayesian statistics, we can individualize our decision-making a little bit better.
Exactly.
Well, let's get to the big outcomes here. And so what did the panel find in terms of the very basic question, should we or should we not use anti-seizure medications to prevent early seizures, which you defined as less than 14 days?
Yeah, so overall, we had 11 studies with 9,024 patients that we included for this particular question for the outcome of prevention of early seizures. 4 of them were levetiracetam versus no ASM or placebo, and 6 were phenytoin versus no ASM or placebo, and then 2 of the studies used a variety of different ASMs. So overall, the risk ratio was 0.72 in favor of ASM, but it was not statistically significant, right? And the confidence interval was relatively wide. There was heterogeneity across the studies that was significant, but not between randomized trials or between different ASMs, but across studies there was heterogeneity. So at the end of the day, it looks like with the studies we included, there's no real difference whether you use an ASM or not for early seizures. For late seizures, there were 5 studies, 2,741 patients. And again, we did not see a difference in late seizures, and there was heterogeneity amongst the studies. An issue with these late seizure studies is that, there's a variable follow-up. Like some followed for 30 days, some followed for 18 months or 2 years, different amounts of intervals in the follow-up. So that's one limitation there. And then, adverse events, there really was only one randomized study or one trial overall that looked at this, and that was the Temkin 1990 trial looking at phenytoin versus placebo. And back in the 90s, there was no measured definitions of adverse events, there was no DSMB, et cetera. So this was kind of vaguely defined per whatever the authors thought was, important to look at in terms of adverse events. When we looked at mortality, there were 6 studies with 4,149 patients, and they looked at mortality rates between 7 days and 2 years. Again, there was no significant difference across the studies. And, there's not a lot of data on which patients had withdrawal of life-sustaining therapy, which is an obvious confounder for mortality studies, particularly in non-randomized trials that are not blinded. And then there's one study that looks at cognitive outcome, and this was an extension of the original Temkin 1990 trial. And this is interesting, and I think a lot of people don't know this particular study as well as one might want them to. But, patients that got Dilantin versus placebo, they were followed at 1 month, right? And there was an imbalance, like patients that had a GCS less than 8 were more likely to be in the Dilantin group than the placebo group. And so at 1 month, the Dilantin group was much worse cognitively, largely because a lot of them couldn't even complete the neuropsych testing. But by the time you got to 12 months, the patients who came off Dilantin had a very fast trajectory of improvement in cognitive scores so that they caught up to the placebo group at 12 months. And effectively, there was no difference at 12 months cognitive-wise. Andy Natick's paper, which is looking at Dilantin in subarachnoid hemorrhage patients, really brought the cognitive issue to the forefront for a lot of people. A lot of people quote that paper because the patients that got Dilantin did worse than those who did not after subarachnoid hemorrhage. And that's where people started to get really concerned about that kind of side effect. But again, that was at a 3-month follow-up, did not necessarily follow those patients for longer duration. And that was not a randomized trial. So, just a word on cognition, just to be wary of when you're looking through that literature.
So overall, it seems like there's a lot of limitations to this literature, and it was really challenging for the panel to have any strong recommendations one way or another. Is that a fair summary?
Yeah, and this applies across basically the whole body of literature for ASM prophylaxis, be it TBI, ICH, SAH, whatever, that, first, seizure detection is a major limitation. So very few papers use continuous EEG, and now we know that most seizures that happen in the ICU are subclinical or electrographic only, right? So there's a lot of bias in terms of outcome measurements if you're just looking at clinical seizures. And that's the majority of the literature here. And then second is, for Dilantin, for example, they were quite good at looking at whether you had a therapeutic level or a Dilantin level in a target range. That is not the case for Keppra. In fact, most of the levetiracetam studies used a very low dose. We recently looked at this in a little over 200 patients. And, if you got only 500 twice a day of levetiracetam, only 45% of those patients were in their target range when you measured their levels at steady state. If you got 750 or 1,000 twice a day, 64% of people were in range. And probably there's a substantial proportion that need even higher doses. So we're vastly underdosing levetiracetam. So it's almost like placebo versus placebo in some of these studies, depending on people's age, creatinine clearance, et cetera. So I think, monitoring ASM levels is important also for neurodegeneration meds, which we frequently seem to underdose. And the issue really is in critically ill patients, there's augmented renal clearance, which most people don't look at, but things that are renally cleared, you're just chewing through them. And, so it's important to pay attention to what the levels are for levetiracetam. And then the last thing is, as I sort of mentioned before, looking at adverse events is not at all standardized and probably underreported. And so that's a huge issue. So, on balance, we did not really see a positive or negative effect for ASMs compared to no ASM for early seizure, late seizure, adverse events, or mortality. And, the overall certainty of the evidence was pretty low. So at the end of the day, we couldn't really recommend doing one way or the other based on the data we had in meta-analysis and based on grade criteria.
So knowing that guidelines don't always actually guide what we do in the ICU, and that probably in most centers, seizure prophylaxis is, I don't want to use the word standard of care, but I guess you would say maybe standard of care. If practitioners are going to offer seizure medications for prophylaxis, any data on whether we should use phenytoin or levetiracetam?
Yeah, so that was our second PICO. And, so when we look at, early seizures, there were 10 studies and 1,741 patients. So decent number of patients and studies. There was no difference between phenytoin and levetiracetam. On the other hand, if we look at late seizures, which there were 3 studies in 208 patients, so much smaller group, there was a significant difference favoring levetiracetam over Dilantin for late seizures, even though levetiracetam was only continued, for 7 days in most of these studies. And a lot of the data was driven by a randomized trial that showed a benefit to levetiracetam versus Dilantin for late seizures. And then adverse events trended towards being higher in patients who got Dilantin, which is not a surprise to anyone who's used Dilantin. So, there were no mortality differences between those 2 drugs, I should say. So at the end of the day, because there's fewer late seizures, or we saw a signal for that, there's a trend towards more adverse events with Dilantin. We felt that if you're going to use something, levetiracetam is probably suggested. And, you should just keep in mind that when we make a recommendation, it's not just based on that summary statistic on the forest plot. So it's not just based on the balance of benefits versus risks. We also take into account feasibility and acceptability, which means acceptability basically means what is the current practice right now? Are people likely to do this or not? And, most people are going to use levetiracetam because the cost differences are not there since it's generic at this point. And, there seem to be benefits. So that's how we came up with, suggesting that if, you're going to use something, use levetiracetam rather than Dilantin.
Okay. And if you do use something, how long should you use it for? I think the group also looked at that as maybe the third PICO question.
Yeah, this is really indirect evidence. So, there's only really one study looking at 90 days versus 21 days of Dilantin, more recent study, and suggested no difference between these groups. There's the bulk of the rest of the literature looked at different durations of different ASMs with no difference in late seizures. And since you're not doing a heck of a lot for late seizures by using a longer duration of medication, it doesn't make sense to expose patients to risk and to the adverse events and to the cost of those medications long-term, or the drug interactions that could be incurred with those medications long-term. So, based on that balance of data, we suggested using a shorter duration.
All right. Well, I think all of that is very helpful and hopefully gives people some answers to some of these questions we struggle with in the ICU continuously. You've mentioned some of the limitations of the data and how you might go about solving them. So I think we talked about changing from frequentist to Bayesian statistics. I think we talked about maybe monitoring more seizure drug levels and making sure that we're adequately dosing. What other changes to study design could be helpful for us to offer stronger recommendations one way or another in answering some of these questions?
Yeah, so I think, the most recent ASM prophylaxis study was a PEACH trial, right? Randomized trial in ICH patients.
Mhm.
And the design of that I thought was pretty well designed, though it was stopped early and there's other issues with that trial. But I think we really have to have continuous EEG monitoring in these patients and looking at electrographic and clinical seizures as outcomes. That's one, because that's your main outcome. You need to know how to look at it, as well as standardized follow-up where you're looking both clinically and electrographically in a outpatient setting once these patients leave. And then, a rigorous look at adverse events with the DSMB. Like that, you just have to do those things. And that's how modern trials are designed anyway. But also making sure that patients actually were within their target range, as I mentioned before, with adequate dosing of whatever ASM it is that you're going to use. So the pharmacokinetics should be incorporated in some fashion in any study that's done. I think it's great to look at functional outcomes. I'm not sure how a power analysis would look for that. But again, if you do a Bayesian style randomized controlled trial, you will have posterior probabilities that can make trial design more efficient.
Great. So let's take this down to the individual decision maker. What are you doing in your practice for patients with moderate and severe TBI? And are you doing things uniformly, or do you somehow tailor it to the patient?
So I will say this is that, my issue with frequentist meta-analyses in this particular case is that the Temkin trial from 1990 was extremely well done, though it did not have electrographic seizure outcomes or, very standardized look at adverse events. It was an extremely well done study with long-term follow-up. And I think the effect of that study was washed out in quite a number of smaller studies that were less rigorously conducted. And so at the end of the day, I do use seizure prophylaxis in these patients, again, because even, Temkin was positive with Dilantin, which is not my favorite drug. So inserting in an equally effective anti-seizure medication with less side effects, I would imagine it would have an even greater benefit. And so we do use levetiracetam usually at higher doses. And it was a big culture shift to get my institution away from that 500 BID thing. And it's only because I've been on a soapbox for a number of years and looking at levels and so forth, to sort of convince people to move towards higher dosing, unless you're on dialysis and you're 98 years old. There are cases when you're going to use a lower dose, but it's not the outpatient dose of 250 BID or whatever some people like to use, which is effectively homeopathic in the ICU setting. So the only way I tailor it might be in the dosing, like I pay attention to that. And I do personally, so many people are delirious and agitated, and it's very difficult to know whether that is the Keppra talking or their TBI talking or both. And so a lot of times I will use different ASMs that don't have that issue. And like lacosamide, which is also available IV. As long as you don't have a prolonged PR interval, that is a medication I will also use.
Great. One approach that some practitioners take, and I've seen more in the ICH literature, is this idea of getting an early EEG and then looking at certain epileptiform features and then deciding whether you're going to continue prophylaxis or start prophylaxis.
Yeah.
That hasn't come up in our conversation, and I haven't seen that practice as much in the trauma population. Is that something that you ever do, or is that a strategy that maybe we should be looking at, is tailoring dosing to EEG patterns?
Yeah, I think that's an excellent point. And there's some pragmatic features. So it depends on your institution to some extent. Are you an institution that has access to EEG monitoring in all these patients? Are you directly managing that TBI or some other team managing it? I very frequently monitor. I'm a huge proponent of continuous EEG, so I monitor a lot of people a lot of the time because, not just for seizures, but you can get a lot of prognostication out of EEG if you have sleep architecture, reactivity, posterior dominant rhythm, all these other factors that can help you with these patients, particularly those that are non-command following. So I think that is an extremely reasonable approach. And again, it depends. Is your patient in and out of the OR? right? How much monitoring are you really going to get during that acute time frame? Those kinds of things are, particularly with the polytraumas, those kinds of things are you should take into account. And, the ICH guidelines are almost ready to come out, and I do discuss the two helps 2B score much more in that, because there's more literature in ICH using that particular scoring system. So, but I do think that, if someone said, hey, I don't want to empirically put someone on ASM, I want to monitor them, look for, two helps 2B score over 1, let's say, which is higher risk, and then I'm going to put them on, or effectively you can narrow it down to, if there's epileptiform discharges, you should put them on something. I think that's a very reasonable approach as well.
Great. Well, why don't we leave that as a little teaser, because I'm going to invite you back on the podcast to talk about the ICH seizure prophylaxis guideline.
Yeah, that'd be great.
I could certainly talk about the PEACH trial for an hour or two. I think it's a fascinating study that I'm still trying to wrap my mind around, because it just doesn't make sense to me in some ways, some of the findings, but I would love to hear your impressions. But let's end that now for our review of the NCS guideline for seizure prophylaxis in adults with moderate to severe TBI. It was so great to have you. And again, we'll hopefully have you back to talk about seizure prophylaxis and a whole bunch of other disease states.
Thanks so much, Nick. I appreciate it.
All right. This has been the Neurocritical Care Society podcast Hot Topic series. This is available anywhere you get your podcasts. Please like and subscribe. And continuing education credits are available for select episodes. Be well.